a co-host, so I think you're able to hit record if you also wanted to on your end.
Okay.
Kind of as well.
Perfect.
If you want to for any reason. So Tim, we actually just kind of met just before we kind of came on here, and this is one of our didactics here as part of the knee. And the goal for this section actually is to talk about only the ACL. So they actually had a couple of readings that they had to read, and maybe you kind of saw them, but they read the APTA Clinical Practice Guideline, for exercise-based knee and ACL injury prevention. I believe you were one of the co-authors on that one.
I was.
And then they also read the NATA position statement, as well as the meta-analysis of meta-analysis, with you and Kate, as well as an article with you and Chris Nagelli on, potentially kind of waiting, kind of 2 years, and the ACL, RSI article, and also the one by Dr. Arden, too, are kind of some of the readings that we use to prepare for this. So hopefully I was kind of hoping just to have, with that background, hopefully just have a discussion with the residents and you just about kind of things related to ACL, and actually did, pose at least a couple potential, kind of topics for discussion to kind of to help Corey if we kind of want to go that way. So how do you want to start, Tim?
If you don't mind, I'm going to ask a question to start out. After all these readings, do you all think that ACL reduction programs are efficacious?
Yes, I do.
So how come ACL, the number of ACL injuries hasn't dropped way down?
So I think I'll let Adrian chime in too after, but I think there's a lot that goes into ensuring quality of ACL injury risk reduction. And so depending on the setting you're in or the clinic you're at, I'm sure there's a lot of variability in terms of both understanding for how to reduce injury risk and also essentially following an athlete through until the point where they actually are kind of, they've had those modifiable risk factors reduced. So I think there's a lot of variability probably in clinical practice relating to that.
That's a great answer, Sarah. I would put in some other factors as well. I think utilization is actually very low, especially for primary prevention. I think compliance by coaches and organizations is relatively low, and those were the papers of my PhD student, Dai Sugimoto, who's now at Harvard with the group, and Lyle McKaylee and that team basically showed that coaches weren't very compliant with the use of it for, I'm sure, any number of reasons, one being time. And then what we do know is if you present it to athletes, they are adherent to these programs if given the opportunity. But I think they're very much underutilized. I don't think coaches and organizations are that compliant with them. And as you could see, even in those position statements, there was some disagreement and variability in what actually goes into a good ACL prevention program. For example, I see this all the time, even in these consensus statements are sometimes less scientific than they are political. For example, I don't think slow static stretching actually prevents ligament injuries like ACL injuries, but we usually incorporate that in. So that got into I battled and battled and battled not to put that into the NATA statement, but it got in because some people believe that it does work. But I think if anything, slow static stretching prior to a practice, a game match, actually has the potential to slow down the afferent, efferent neuromotor response. So I don't think it is optimal. It may not have a negative effect, but even though, in 1 year, in the year of 2018, we put out that big APTA clinical practice guideline, and like a month later, well, a couple months earlier, actually, we put out that in Journal of Athletic Training, that NATA statement. And then about the same time, we did that meta-analysis of meta-analysis and published that in Journal of Orthopedic Research. I think there's still some variability in what people believe to be true regarding what are the effective components of an ACL prevention program. The good news of all this is, if you look at the data of anything in sports medicine, orthopedics, physical medicine, and rehabilitation, that effect is real and it is large. I mean, it's somewhere between 50% and 67%, between a half and 2/3. You don't see that large and that consistent of an effect of almost any modality or any intervention in orthopedics, sports medicine, physical therapy. You just don't see it. So I think the effect is real there. I think even though we've put out these multiple consensus statements, I don't think there's necessarily good consensus nor good implementation of these programs, which is pretty sad, especially when we, started publishing this work more than 20 years ago, 25 years ago.
Tim, do you think if it was advertised as injury, but also as performance enhancement, do you think that would help with buy-in? And my second question, is the terminology. And again, I saw maybe even recently you got maybe into we all know you're a Twitter troll. Maybe you got into I don't know what you want to call it, a disagreement on some of the terminology of injury prevention versus, say, injury mitigation, injury reduction.
Yeah, so we actually, I started that battle out. I do love that, and I have to admit this, I am a major troll, and I love to argue for the sake of arguing. There's no doubt about that. But I also, it's not just out of pure orneriness, although that part does exist. I think it's also about, I like good debate, good discussion. I think that's how we move science and the field forward. So I actually wrote a paragraph in the discussion of that meta-analysis of meta-analyses about this use of the term prevention. So we've been in a battle with a group, an international group for several years now about whether you can predict injuries or not. And this is a whole, I've written papers about this. If you want to look at injury prediction, look at that paper, that commentary that I wrote a few years back in JOSPT about prediction of injuries using primary and secondary ACL injuries as a model. But let's go back to this term prevention. So I argued in that paper that the term prevention, if you can actually prevent an injury from happening, that means you could predict that specific injury was going to happen, right? Because if you're going to prevent something, you have to know that it's actually going to happen. So if you're going to use the term prevention, then you're going to have to use the term prediction. And if you say, I can do the one, you have to say, I can do the other. So it's rhetorical and it's semantic in a way, but I think it's important. Why is it important? Well, when you put forth, whether you're advertising or whether you're talking to a parent or a coach or an athlete, and you say, I'm going to do this prevention program, your liability, your medical and legal liability just went way up because you said, I'm doing something that's going to prevent this injury from happening. Now, if that injury still happens, which is we know with these interventions that it is going to happen, it's going to happen somewhere between a third and a half of the time, even after you do this intervention, then they say, well, well, you're at liability. You told me what you did was just going to prevent my child's or my athlete's injury from happening. So prevention, although it's used ubiquitously, although it's going to keep being used, we're not going to stop it from being used. I just say use it with a caveat, with a warning that really what we're trying to do is not prevent an injury. What we're trying to do is reduce risk. And I think prediction in the same terms, we're never, people, we use the term predict in our papers because that's the term biostatisticians use. And I'll say those sections of the results of those papers were initially written by biostatistician, and then I did rewrites and edits of their rewriting. And I must say I kept the word prediction in there because in biostats, that's the term that's used. However, that also has a caveat and some warnings with it, in that we really can't predict anything any more than a meteorologist can predict whether it's going to rain this afternoon. And I can tell you they've been pretty bad of late. If they can predict half of the time whether it's going to rain or not, that's really beyond what their level of prediction is. So careful when we use the term prediction. It's more risk stratification. What's the relative risk of, say, one group of athletes relative to another group of athletes? And I think we can use science and screening tools to do that. And then what we do is we want to train and we want to reduce risk in everyone. But if you can stratify and you know what your higher risk group of athletes is, you can focus and target training toward that higher risk group, which in the end, we've shown in multiple papers that we can reduce the risk more. We can alter the risk profile to a greater level in that group that demonstrates the higher risk profile. And we published that in several papers in American Journal of Sports Medicine off of what we call our core RCT intervention grants that we've been doing for the last 15 years or so. And it does make those interventions even more efficacious.
I had a couple other, talking points, but first of all, maybe kind of really want to see maybe AJ or Sarah, any specific talking points, that you want to kind of talk with Dr. Hewett on?
So my passion is rehab after ACL reconstruction. So I'm really interested in just optimizing our ability to return athletes to sport. Because right now, to be honest, those rates are really suboptimal. We don't do a great job overall. At least a third don't return to sport. And depending on the study you look at, it could be a higher rate. So I guess one thing, there's plenty of factors that can play into that, kind of like we talked about, also play into injury risk reduction. I think you could point to all of those same factors, like the clinician, the athlete, potentially, the contextual factors, like where they are at in sports. But I think one way is potentially the tests we use and maybe how good our tests are. And I know just in terms of addressing those suboptimal rates, we need more research on how good our tests are. So I don't know if this is a topic you'd like to discuss or not, but this is definitely, in my clinical practice, this is something I think about a lot, but basically how good my assessment is of the athlete. So
I definitely, that is a strong passion of mine and our team over the last couple decades. When we first started doing these studies back in the mid-90s, and then in the early 2000s, we actually started looking at an entire county school system, Boone County, Kentucky, that's where the greater Cincinnati airport is. And they they had a recent Title IX lawsuit against the district that complained that they weren't giving their female athletes as much attention as male athletes. And when we went in and looked at the situation, what we saw is that they had a massive number of female ACL injuries, way beyond what you'd expect. So they let us in there for the next more than a decade, where we tracked those kids. And what we did is we first just tracked the kids. We started with these prospective studies, and we saw this much higher incidence in girls than boys of ACL injuries. And then what we did is we started screening and identified athletes at risk. And that's that identification prediction paper that we published in 2005 in AJSM. And then what we started to do was the next leg of that, next 5 years of that grant, was see, could we predict who is at risk, which we showed we could risk stratify these kids. But then finally, the school system got the payback. And those papers were just published last year in AJSM and Journal of Athletic Training and other journals, where we showed in that school system, we actually could significantly alter the risk profile and reduce the risk of ACL injuries, especially in those high-risk kids, girls being one. Well, what we kept doing is following that cohort over time, and what we would see is the high, you know who the highest risk kid is? The highest risk kid by far is the kid who's already had an ACL injury and had a reconstruction. So those were the scary high-risk kids, because what we found, and a lot of this is the work of my colleague Mark Paterno, it was his PhD work, and he started publishing this work around 2010, is not only could we identify the risk, but we saw massive risk. What we saw is, and he recently presented this at the last AOSSM, the last two AOSSM meetings, a lot across the last 2 summers, where we showed that there's basically 2 groups of high-risk kids, which makes this really scary. Now, why? Well, the kids that can blow through everything really easy, like superstars, they look symmetric, they look strong, they get back really fast, like in the 9-month time frame. Many of them, about a quarter of them, have a second ACL tear, which is really scary because, well, then you have to look at the other group. So then there's another group that fails everything. They take a long time. Very often they don't even pass, but they go back to sport anyway. Very often at that 9-month time frame, because that's where everyone believes that's what you need to get back. And that's usually, usually they've torn their ACL in mid-season, and 9 months later, they're starting preseason and they go back, and their risk of another tear is about a third. So now you've got these, now this obviously makes risk stratification in this group extremely difficult, because you got your superstars that can pass through everything, get back fast, and they have a quarter risk of a second ACL tear. And then you've got your other group that does poorly on all the tests, they go back anyway, and they have a third of a chance of tearing another ACL. No, in my lab at Cincinnati Children's, at one time we had 6 people in the lab with 2 ACL tears and 2 ACL reconstructions at least. That second ACL tear, the first ACL tear in reconstruction rehab is really, really tough. The second one is both physically and mentally devastating. And that's why we had so many of these double ACLs in the lab, like my right-hand guy, Greg Meyer, and my left-hand guy, Kevin Ford, in the lab in those many years of the group at Cincinnati Children's. They're both bilateral ACL reconstructions. And it makes you want to think about, wow, this is such a terrible thing. how do I figure out why this happened to me, and how do I apply that to that high risk group of people, that which are people that have had that ACL tear and reconstruction, and how do we prevent that from happening again? And there's a new paper coming out any day in Clinical Journal of Sports Medicine where we show the downstream effects for osteoarthritis. They're not as great as we once thought they were. Your risk at 10 years is about 36%. Other people have said it's much higher, like 50% plus. If you look at, so this was also an umbrella meta-analysis. We did a meta-analysis of all the meta-analyses in the literature. What we did show really interesting is your risk of osteoarthritis after tearing your ACL is about 6 times higher than somebody who hasn't torn their ACL, that osteoarthritis in the knee. And it's 6-7 times higher, and it's another 7 to 8 times higher after you've had it reconstructed. So that's another kind of difficult, problematic point, because reconstruction doesn't protect you from osteoarthritis. That's clear. And if anything, it actually slightly increases the risk of osteoarthritis in that joint. Now, as I think many ACL surgeons would argue, well, that's not due to the surgery itself. It's because we've given you a more stable knee, and you're going to be more active on that knee, maybe even turn you into what some people would call a knee abuser. You probably shouldn't be using that knee as much as you are, and then you have even more osteoarthritis. So going back to these high risk groups, Sarah, this is your passion. How do you deal with those two populations, and what testing do you use to deal with the kid that obviously is failing everything, is barely getting back, and then the other kid who looks like a superstar is running through and looks like they're ready to go and they want to get going early? I mean, how do you address both of those populations?
It's a great question. I think for both, first off, it's a lot of education, because the athlete needs to know that on this decision is basically weighing risks and benefits of like when to go back to sport, as well as like assessing their readiness at that time. So basically that athlete who just crushes all their testing, it seems like they're really ready. I mean, one of the things we can definitely point to is like athletes who go back before 9 months, their outcomes are really just not as great as people who wait at least 9 months to go back. And I know another thing we can point out is I know you have the study saying for the biological healing, it takes at least 2 years for that graft to be like biologically set, if that makes sense. And so when I think of that athlete hears that, sometimes that kind of puts things into perspective a little bit. But for that person who's crushing their tests, it seems like one of the things that I wonder if kind of can sometimes slide out of view or not get as much attention is like movement quality. Because it's harder to assess movement quality objectively with like our battery of tests. So we've got great tests for like strength, the isokinetic dynamometer, for hopping with the noise protocol. And you can look at LSI, but when you're hopping, for example, it could potentially, if the clinician is not looking at quality, they may pass based on LSI, but what if it just like they're favoring that surgical side still? So that's kind of that's a topic that sometimes that interests me, is that we know even if there's some studies that show even if people pass our battery of tests, they are still at an increased risk of injury. So the question that comes up is, well, how good are our tests that we're using? And so I wonder if that's an area for us to further improve, is the assessing kind of movement quality, but it's a hard thing to assess because there's subjectivity involved with that. Obviously, unless you have like a motion capture system, which not every clinic is gonna be able to do for every athlete. So it's a hard question because we want to improve what we're doing, and I think it takes some thought in terms of how we can best serve that athlete.
Yeah, so let's go to that wait 2-year paper. Actually, I noticed there's a guy on I just started playing around. I'm very late to the game with YouTube. And so I just started my own channel a few weeks ago, and I connected with Brian Sutter, who's actually a PM&R resident there at Mayo. Sharp guy. He's really good. He has like, I don't know, 275,000 followers. And what he does is he looks at injuries in sports, and then he does anatomical and medical commentary on what his takeoff on it is. And usually it's pretty quick. He pulls the video down and then watches it. And well, there was when Klay Thompson last year tore his ACL, I had a couple reporters, you know, during the crucial time, I had a couple reporters call me, and they had picked up on that wait 2-year paper, and they kind of just went with the story. As you'll find with most of the news and media outlets, they already have the story they want to tell in their mind and are just looking for something to back that up, and they sort of selectively pull out what you say. And what they said was, oh, this top knee doc says Klay Thompson should wait 2 years to come back. Well, Brian got a hold of this and said, you know, for one thing, this guy's a different kind of doc. He's a PhD. And then secondly, you know, yeah, this is there. The science is really strong, but Klay Thompson isn't going to wait 2 years. You know, it's funny. I thought up that idea for that paper. I think it was in 2008. I was at an AOSSM meeting, and I'm just jotting down. So I'm just going through. I was moderating a couple sessions, and I was sitting back and listening to abstracts. And what I kept noticing was, so I saw Scott Dye speak on his bone scan data. And basically what Scott Dye has shown for 25 years is the knee joint remains hot for somewhere between 18 and 24 months. And he said, if you really want to look at it and figure out when that immune response comes down in the knee, it doesn't resolve till about 2 years. And then I saw another presentation from a Japanese group on hamstring ligament healing, and what they showed was the graft doesn't ligamentize. You know, you're taking a tendon and trying to, over time, you hope the body turns it over cell by cell into something that's more like a ligament. And they showed that a hamstrings graft, that doesn't occur till about 2 years. And then I was looking at another study, and basically they were showing proprioception kinesthesia in the knee joint, and they said that doesn't come back till equal on both sides until about 2 years. So I started looking at all this biological data, and it's not like I was really thinking about it. I'm just jotting this down, and I keep writing down 2 years. Well, and then strength. If you look at hamstring strength post a hamstring ACL graft, in many people, it never comes back to equal side to side, but to get to equal on average in a large cohort, it took another study, shows about 2 years. So this 2 years kept popping up. And I jotted down like 7 different things during that meeting that related to 2 years. Well, even though I'm not a real doctor, I'm just a scientist, it kind of hits you in the face to say, the biological data, the physiological data shows that everything doesn't normalize for about 2 years. So I knew that if I put that out there, that I would be ridiculed. Nobody's going to wait 2 years, right? So Chris Nageli, a PhD, a student of mine, because I was afraid to write it up. So I said, here's all the data, here's all my observations, here's all the references, take this and write it up, because I don't want to do it myself. So we ended up doing it together, and we got input from several people. And just to bounce it off clinicians, MD clinicians, PT clinicians, because I was afraid to put it out there. But interestingly, at a AOSSM meeting just after we published it a couple years ago, I presented it in an AOSSM meeting, and I thought, man, I am going to get slaughtered. Right after I got done, I walk off the podium, and Freddie Fu, one of the top ACL surgeons in the world, came running up to me, and he's like, Dr. Hewett, you're right. We need to get them to wait. And then Jimmy Andrews came up to me in his southerly gentleman way and said, Timmy, I think you're right. And I was, for both of them, I was blown away. Now, if you talk to them further, they're going to say, yeah, you're right. Now, no one's actually going to do it. But, and this is, I've had this discussion with Mike Stewart at Mayo, and he said, Tim, what I do is I take your paper, I bring that in with the young kid and the parents who want to get back in 6 months. And I say, I know you're going to want to get back in 6 to 9 months. Here's what the science says. The science says everything isn't going to normalize or even come close to equal side to side for about 2 years. So let's start thinking about a time frame somewhere in the middle there, somewhere that you can deal with.
Right.
And I can deal with it. And I can tell you a lot of clinicians have said, yeah, we're going to, and we kind of wrote it in a tongue-in-cheek way. What we said is objectively test. We need better, we need more validated tests. However, if you're not going to test it all, and I'm telling you, a lot of people aren't. If you're not going to really, what they do is they come back at their 6 or 9 month appointment, surgeon does a Lockman's test, and they say, looks solid, go. And our point was, if you're going to use time as only the criteria you have, then you better wait 2 years. So it was a bit of a tongue-in-cheek way in that we wrote it, but we were trying to, the science is real and the science is solid. If you look at any recent publications in any of those areas, the bone scans are still hot, the balance is still off, the strength is still down, the graft is not matured, and that kid's going back, that young athlete's going back, and their risk is really high. Now, we can't really answer whether if you shift them back, that there is going to be a reduction. Now, there is a group based in Austria. I call them the Christians. They're 2 top ACL surgeons in Innsbruck, Austria. And they recently just published a paper that showed if you do move them back, you do reduce the risk of that second injury. But that's a first paper, and we still need to figure out, are we just shifting that time of second injury back, or are we actually really reducing the risk of a second injury by delaying return? We haven't really, there's some early indications that we're actually reducing the risk of that second injury, but we haven't really figured that out yet, whether or not we're just shifting back risk over time.
Right.
Hey, Tim, I just stopped the video on my end just because we're having a little bit of some feedback issues to see if it maybe helps a little bit with our bandwidth, just as a heads up. But we're still here.
Okay.
I had a quick question for you, Tim. So far, I think by my count in the NFL this year, there's been a total of, I think, including the Packers tight end on Monday, 23 ACL tears in the NFL this year,
That's
including
right.
Numerous other Achilles tendon ruptures, including, I think 2 weeks ago, there were up to 8 ACL injuries on one day on Sunday. So I have a question for you, or discussion twofold. What do you think the role of ACL injuries in turf versus grass? And then secondarily, do you think we're seeing more because of maybe a shortened training camp and no preseason games?
Yeah, so this COVID thing, and for one thing, we've had a really low exposure, a shortened and low exposure preseason. We predicted this to happen along with a lot of other people. Now, the ACL injuries aren't 23 is not, well, we're early in the season. We don't know where we're going to end up, obviously. That's around the number that we usually get during a preseason. But obviously, it's really hard to compare because in the preseason, you've got over 100 guys in camp, and a lot of those guys that, go on to ACL injuries don't end up making the 55 squad. So it's such a weird situation this year that it's hard to compare. You've got so many confounding variables in there. But to have 8 ACL injuries in a single, that's a record. I mean, it's got to be, and that's a crazy situation. So yes, I do think this shortened preseason, this lack of exposure during that time, that whole time prior to that, the 3 to 6 months prior to that, where people were on lockdown and they didn't have as close a connection to their medical team, to their strength staff, to their athletic training staff. I think that is a big problem, and I do think we're seeing the result of that. And then you're putting these relatively unprepared players onto these super sticky rubberized turfs. So what's the data on these rubberized turfs? We did studies years ago where we didn't show a difference between grass and the old AstroTurf. That was in the early 90s. The old AstroTurf was hard plastic. It was probably tougher on the joints. So overall, it's hard, but it's not all that sticky. AstroTurf was kind of slick. I think many of you may not ever played or even that familiar with AstroTurf, but the new field turfs, they really grip, especially if you've got a spiked shoe on. I mean, they really hold on to that foot. And there's pretty strong data in the sport of American football that there's a higher risk, and it's more than 60% higher risk of an ACL tear on these new sticky rubberized field turfs than natural grass. There was one study published, it was actually performed by what was a whole group of NFL team physicians, and what they showed was a 67% greater risk of an ACL tear on these new rubberized field turfs than exists in natural grass. Now, the interesting thing, so you pop an ACL in a player, so any of the high level skill players now in the NFL are, $20 million a year players. So they're and it seems like, well, on a couple Sundays ago, out of those 8 ACLs, like 5 of these people were like superstars, $25+ million a year players. But you haven't seen a regression by the NFL into the use of grass, which makes you wonder why, especially when the NFL and the NFL team physicians were the ones that sanctioned and did that study. And why that is, I can't tell you. There's many issues of, obviously, with these new stadia with their, I don't know if you've seen the new Vegas one, the Starship Enterprise, but that thing, the field even, completely retracts. It's just much more convenient and easy to use, rubberized material than it is to use real grass. But it's a problem, because if you've got $25 million a year players out there and you're using them for, you're losing them for a year. So that just last Sunday, that was like a $200 million loss to the NFL. To go back from a field turf to a grass turf is going to cost you maybe $500,000 to $750,000. Nothing compared to just what the law $200 million loss was on that couple Sundays ago.
At the high school level, though, probably having field turf, like at Mayo High School, for example, probably allows you to have numerous sports.
Yes.
So Thursday you can play a soccer game, Friday you can play football, Saturday you can play, lacrosse, and you can also have the marching band practice on there, which obviously you probably could not do if it was turf.
No doubt about it. The convenience level is much greater on a turf. And the NFL stadium, they try to make, the owners try to make more money by doing all kinds of different types of events on their fields. But it's, at least at the NFL level, we don't really have great data at the high school level. But at least at the NFL level, there's pretty strong data, and there's pretty strong data at the collegiate level as well, that those new sticky rubberized field turfs have greater risk. There's about 67, about a 2/3 greater risk of an ACL tear, and about a 35%, say a 1/3 increased risk of a high ankle sprain on sticky rubberized field turfs versus grass fields. So, I mean, you have to set your priorities, and I understand the fiscal, the economic, the convenience factors that have pushed field turf so far down the way. By the way, a new field turf field costs about $250,000, about $700,000 in that range. So a lot of high schools that I've worked with have gotten their boosters to raise the money, and like as Corey was saying, look at all the things we can do if we don't have to deal with a torn up grass field. In high school, I played football on a grass field, and I can tell you we played in a lot of mud. So, the convenience factor is much higher.
AJ, do you have any kind of questions or discussion points?
So with relationship to the stickier field turf, then, has there been anything investigating your traditional spikes versus like more turf-based shoes? And does that play a role in mitigating?
Yeah, there's more of that. It is being done, and I've lost multiple lab managers over to the big shoe companies because they're interested in those questions. The problem is they don't publish that work. And so there hasn't been a lot done on, the interface, the relative interfaces. I can only tell you, our group did a study back in the 90s where we said, what would it take if you wanted to reduce the risk of an ACL tear? What would you have to do? And, to reduce the coefficient of friction down low enough so that you'd almost negate the risk of an ACL tear. And what we showed is you'd almost have to have a bowling shoe on wet ice to reduce the risk of the coefficient of the foot to negate the risk of an ACL tear. So that's obviously way down the line in another direction. So I can't tell you, there's not been a lot published on it, and most of what that's been done is with the shoe companies, but I don't see them changing shoes at a really high level. That the athletes, will say, after that Sunday before last, you heard some top level athletes saying, we got to get off this turf. I noticed that the next week after I play on turf, my body's beat up, my joints hurt, my body aches so much more. But it's mostly just anecdotal information, how we can modify shoes and turfs to really be able to reduce that risk. We don't know at this point.
Hey, Tim, what is your opinion on the role of bracing for the ACL for either prevention, and or return to sport?
No, I get in trouble with this question because the brace manufacturers don't usually like my answer. The study that I go back to was the study done in the Big Ten, was published in the late 80s. John Albright was the first author. It was published in AJSM. And basically what they showed was that braces don't reduce the risk of an ACL tear. What they showed was that in defensive backs that really, are backpedaling a lot and really need that hamstring activation, basically they showed a slightly increased risk of an ACL tear in DBs. In other skilled players overall, who are usually the players that have the ACLs, there was no reduction. The only thing they showed, and this was the big bulkier ACL braces, they showed a slight reduction in interior alignment of MCL sprains. And that's why you still see to this day, especially in the Big Ten, but other conferences as well, that they use the interior linemen, use those big bulky ACL braces, because what usually happens, as you know, MCL sprains tend to be direct contact. It's a guard or a center, and the tackle rolls their leg, with a straight valgus contact force. That showed a slight reduction in MCL tears. There was one recent study out of Boston that demonstrated this was with the grafts, these new biological grafts they're using. In conjunction, they used a brace, and they showed with those biological, repairs, that they showed reduced risk of tearing that repair with the use of a brace. That was recently published. That's the only thing really in a randomized fashion that I'd seen the support of a use of a brace post-operatively. I remain skeptical, but we'll have to see as we move forward. I think the vast majority of clinicians would say, and it would say braces don't prevent an ACL rupture, either from a primary or a graft rupture from a secondary intervention. I don't think so. No, biomechanically. So if this is your knee joint, and you put so that's a cylindrical structure, and you put a cylindrical structure around it, and to get an ACL tear, basically what you need is about 3 to 5 millimeters of anterior translation, maybe 5 to 6 degrees of internal rotation, and maybe 6, 7, 8 degrees of valgus combined. A cylindrical construct on the outside of meaty, fatty tissue is not gonna stop that from happening. And I think you saw that. One of the better examples of that is with RG3 playing for the Redskins. To protect that graft, they had put a cylindrical, ACL brace on there, and man, that thing went into valgus and ruptured his graft. I'd say that the preponderance of the data would say it doesn't prevent a primary or a secondary tear. But again, I don't work for or with brace companies, and I don't try to, pump them up or put them down either way, to tell you the truth.
Sounds good. Hey, Tim, I updated your name for you there.
Say again. Good
I updated
luck
your
with,
name
good,
there
good,
for you
good
this
luck
year.
with that, Corey. It's not fair.
Hey,
You got.
Tim, if you had an 18-year-old,
Go ahead.
you got control.
Yep.
Tim, if you had an 18-year-old female, you know, high-level soccer player, ACL, nothing else, and, you know, again, you're an outstanding surgeon. What type of graft would you recommend?
You know, that's a tough one. I will say this. Again, I'm not a surgeon. I'm not a clinician in any way. I would just say I would stay away from a hamstrings graft for multiple reasons. So what we saw, I worked in Cincinnati for a couple decades. We worked with many different surgeons. We were at Cincinnati Children's Hospital, so we were, you know, sort of in the neutral zone. So we worked with surgeons in the adult side, pediatric side. And what we would see is that, so we worked with the guys that, you know, were the Bengals team physicians, and these same surgeons that would say, no, the bone patellar bone graft is the gold standard, and that's the only thing we're putting in an NFL athlete. They would put a hamstrings graft in that girl, in the 18-year-old high school kid, who, by the way, really needs her hamstrings. Female athletes tend to be quad dominant, and if and when they fire their hamstrings, they tend to be lateral hamstrings dominant. And you're taking someone who's underutilizing, underactivating their medial hamstrings, and then pulling them out and using them as the graft. Now, there's some pretty overwhelming evidence in randomized controlled trials that hamstrings grafts stretch out more than do bone tendon bone grafts. And there's also pretty overwhelming data that this happens more in more lax individuals like female athletes than happens in male athletes. So I would argue, if you're going to have a bias toward one sex versus the other, I would put the hamstrings in the males, because the females need them more and they stretch out more in women and girls. So I don't think hamstrings grafts are a good idea in that athlete. Now, and I know a lot of surgeons who would agree with me, but then you say, well, what do you know, there's the whole issue there's some evidence, and there's some evidence against it, that with bone tendon bone grafts, you're going to get more patellofemoral pain. I don't know that the evidence on that is not that strong, but people will say, well, to keep the women and girls away from patellofemoral pain, you know, don't use a bone tendon bone graft. Now, my bias these days is the quad tendon graft. I do like the quad tendon graft for many biomechanical and epidemiologic reasons. But I think the problem is, one of the reasons we like it is because it hasn't been around long enough to show high failure rates. Now, there was an initial study based out of the Denmark registry that actually showed a higher failure rate of, so when you talk about failure rates, they're all relatively low when they're reported. Sometimes it's a little scary, because in these registries, I don't know who they're looking at, but they have a really low graft failure rate. And sometimes what they'll show for like a bone tendon bone is like 3%. And then what they'll show for a hamstring is 4%. But the hamstring is always showing to be at higher risk of a re-tear than is a bone tendon bone graft. And then what they showed when they just looked at the Danish registry, what they show was about a 5% failure rate in quads. Now, they've re-looked at that data over time and factored in the learning curve and lots of other surgical issues like fixation. And now they've said that the quad actually performs well comparative to a bone tendon bone. So the jury's still out. There's not a perfect option. The one thing I would say, allografts, especially in young active athletes, don't use them. An allograft has its place in a 40-plus person who's not really going to test that knee, perhaps, just play maybe a little recreational tennis. But in a young, active football, soccer, basketball player, allograft is a really bad idea.
Tim, thank you. I know we're kind of running close to our timeline, so I just kind of want to kind of see if AJ or Sarah had any additional questions or comments, or if you had any additional discussion. But Also, I just want to greatly thank you, Tim, for kind of spending, taking time to, share your expertise as, really one of the leading, kind of researchers, on this ligament.
Now, the pleasure is all mine. I think we covered everything that I wanted to talk about. I thank you, Sarah and AJ, for listening to me pontificate the way I do. Follow me on YouTube, Tim Hewett, PhD. I need subscribers. Click for notifications, and don't forget the major twits. So I'm a twit troll in three places on Twitter: Tim Hewett 5, Timothy Hewett 1, and Hewett 1 Tim. Follow me, argue with me, challenge me, question me. I love it. I never have more fun than that. And happy to give back input anytime.
Tim, I saw on your YouTube video channel, there's a nice picture, but you cut me off. It's only my arm.
I do not.